Thank you very much. That was a truly informative presentation. It really stressed what a great workflow and teamwork that you had in implementing this system. And that's where I'm going to start maybe some of my questions as well. You had such wonderful teamwork that you shared in your presentation. And I wondered if microbiology was the first to introduce this to your team, or how did you really go about starting all of this process? Was the microlab the first people to learn about the Phenol system? And so many people have asked me, how do you start this process of developing a team? So could one of you just take a moment to discuss that?
Sure. Our antimicrobial stewardship team works tremendously closely with the microlab. Kelly and I and others in the microlab, we talk numerous times a week. They're on our antimicrobial stewardship subcommittee. We're constantly reviewing new opportunities to improve the care of our patients. So it's truly a collaborative effort when we're evaluating new technologies. We want to make sure that, one, they enhance the lab's workflow, two, that they would bring real value to our patients, meaning would our stewardship team be able to act upon the results? We don't want to just implement some fantastic technology, but not have the ability to realize and reap the rewards of such a technology. So it's really the implementation, I feel like, that is more important even sometimes than the technology, because the best technology without a proper plan and how to act on the results doesn't add tremendous value. So we're constantly discussing, for each of these high yield disease states, what are our opportunities? What works for the lab? What would work for our stewardship team? Are we able to align the goals of each for them? And we had started off initially, we had presented with the gram-positive cocci in clusters for bloodstream and then non-bloodstream. It really was a natural progression that we really needed something to help us with our gram-negative bacteremia. And we were evaluating the different technologies with our patient population across our health network. We don't have as much. We certainly have resistance, but our biggest issues aren't a tremendous amount of CRE and multi-drug resistant Acinetobacter. We see those, but for us, it was more important what we see that would be tremendously helpful or for the patients with a pan-susceptible gram-negative bacteremia. That's what we see 10 times more often than a pan-resistant gram-negative. So we really wanted to make sure that a technology that we had in place was going to benefit those patients, not just the patient in an ICU on 3 pressors with CRE in the bloodstream with escalating therapy. We also needed help with ensuring we could de-escalate therapy rapidly. And that's when we were discussing these strategies where we landed upon this technology.
So Dr. Stefano, if we were speaking to someone in microbiology and they say, God, Dr. Stefano, you're so lucky. You have such a great relationship with Dr. Walsh and your multidisciplinary team. How could you advise them the first person they could reach out to? Would it be infectious disease? Would it be pharmacy? How could they start? Because not everyone's as lucky as you are.
Yeah, I think that we start at the leadership level, to be very honest. Our leadership is very supportive of collaborative efforts and multidisciplinary teams. When I first came on board, I think that was stressed that it was needed to go out. And one of the things that I do as part of my job is to work with the clinicians to identify needs from the laboratory. I was able to evaluate the technology quickly. Dr. Walsh actually is the one who made the ultimate decision to move on the accelerate, but we knew from a lab perspective that we needed additional support and that we needed to move things faster to be, better for our patients. So I think in this case, in the case of AGH and West Penn, it is infectious disease or the actual PharmD. Our PharmDs and our infectious disease fellows all go through the laboratory for at least a month, and that allows them to see our side of it. And we have now started doing rounds with the infectious disease folks as well to be able to see the clinical side. So I think merging the two different worlds together, it allows everyone to see all the complexities of each side and why it is so important to communicate.
Yes, it's certainly a great model for everyone. My second question is, did you ever seriously consider using just genetic testing and ID for your gram negatives? Did you ever go that direction at all, or did you go directly to using the Phenol system?
We had discussed the other technologies that provided more of the ID with genotypic as opposed to phenotypic susceptibility. We ultimately went with Accelerate because what we felt like was those were more to help with escalation of therapy. They really help with your beta-lactams to see, I have an ESBL producer that's a CTXM and I need to escalate therapy, or I have a carbapenem-resistant organism that helps me escalate therapy. And again, many of our hospitals, the percentage of our gram-negative isolates that are ESBLs or CRE or multi-drug resistant Pseudomonas or Acinetobacter aren't plentiful. So we thought it would be more beneficial for the patients that we had rapid ability to de-escalate therapy by having fluoroquinolone MICs available quickly, because that's more of our patient population. So I think you really need to tailor what you're going to use to meet the needs of your patients. That's why I think the collaboration is so huge, to really be able to understand the needs of not just your lab and your infectious disease, but what are the other key stakeholders' needs. So making sure you're in line with your critical care physicians, with your quality team, with your hospitalists, and really what do they need? What is going to benefit them? And that's where we felt like the preponderance of our organisms are pan-susceptible. We needed help more in those patients as opposed to the genotypic testing.
I would also add to that, we started using genotypic testing even before the Accelerate was available. And we found that our pharmacists were so just discouraged from using it because they had to have almost a lecture every time they called a physician, trying to explain to them what the genotype meant and to try to change the therapy. And we had much less acceptance of the change of therapy, whether it be de-escalation or escalation, based on genotypic testing than when we switched over to the Phenol. Phenol, we virtually have 100% acceptance. It's a sensitivity, it's the end product. And so that's why I was asking you, because we just saw such an improvement in our acceptance when we did switch to Phenol.
Yeah, I think it really goes to, you have to have that collaboration and education up front before you implement any of the technologies, because it's easy to convince folks to escalate therapy. It's very easy to say, you're on ceftriaxone, we think you should be using a carbapenem. You're on a carbapenem, you should be using ceftazidime, avibactam. It's easy to convince folks with the results to escalate therapy. It's harder to de-escalate therapy. You meet sometimes the resistance of, well, they're doing better, I don't want to change anything. So it really takes a lot of that upfront education to explain why is tailoring therapy and de-escalation so critically important, because it's those downstream effects that they're not going to see from that patient, but they're going to see down the line in your C. diff rates, your resistance throughout a hospital. So I feel like it's a lot of that upfront education to get the buy-in from the local primary care providers to see why this is so important to implement, which is why I feel like we do a great job across AHN of working collaboratively, not just from the lab and stewardship, but with all of our clinical care providers that this is going to impact.
Thank you for that. My next question goes to both of you. Why did your stewardship group choose to only use the gram-negative part of the Phenol panel, and you decided not to use the gram-positive and you went with other methods?
We felt like for the gram-positives, what we really only needed there was the genotypic part. When we have gram-positive cocci and blood cultures, what we really need to know is it Staph aureus or not? And if it's Staph aureus, do we have the MECA gene or not? That's going to give us what we need the majority of the time to be able to escalate or de-escalate therapy. So we felt like for the gram-positives, it was much easier to have genotypic testing as opposed to full phenotypic susceptibilities for the gram-positives than it was for gram-negatives, where resistances tends to be more complicated, more mechanisms. We really felt like we needed more of the full MIC data rapidly for the gram-negatives as opposed to the gram-positives.
Yeah, from a lab perspective, we clearly see far less gram-negatives than we do gram-positives. So from a workflow, initiating some a new technology and a new way of doing things 24/7 was really important that we succeeded. And to succeed, we needed to really evaluate what workforce we had, how much we could handle taking on at one time. While we would love to be able to do everything on every instrument, it is not feasible from a time perspective or a cost perspective. So I think that the biggest outcome was going to be with gram-negatives. We talked about it at length. And while we've chosen to go other directions with the gram-positives, they're less costly, less labor-intensive direction without compromising the outcome of the patient.
Yeah, we chose to go in this same direction as you did. And I think it makes perfect sense. It does mean bringing a few more systems into your laboratory and having maybe a bit of a more complicated workflow, but I think it's worth it for sure.
Absolutely.
Thank you for that.
I totally agree.
Yes. So the next question I asked Dr. Stefano, what was your biggest challenge in implementing this overall comprehensive program? Was it microbiology? Was it dealing with pharmacy? Was it dealing with Dr. Walsh? What was your biggest hurdle that you had to overcome in implementing this beautiful bundle?
I do think that we had, a few burdens and hurdles to get through. I think the hardest thing was to be able to train everyone in the micro lab that was involved initially to make all the phone calls, if you will, to have the direct interaction and contact with the clinical team. We have not typically done that. Most of our instruments are interface direct. We do call critical results, but we don't have to call every single step of the way. And because the ID and susceptibilities are one cartridge, one test, we would have to set timers and go back and look at the results in 2 hours, print them out, and go ahead and scan them in so that we could collect all the data points. So from that perspective, I think it took a little bit more push and a little bit more training and buy-in from the laboratory to be able to do the additional work. Once they were able to see how well it performed and the outcome at the end of the day, we didn't have any trouble getting buy-in from the rest of the group to get on board. But the initial evaluation is always more work and why. It's, are we going to see a positive outcome? And we knew it up front, but they did not know that up front.
So Dr. Walsh, do you have a comment to that?
Yeah, I think one of the things that I feel like is really important is being able to know how are you staffed for success with this. I feel like it was one of the things that could be a potential barrier for a lot of stewardship teams that fortunately for us wasn't, just because we're in a position that not a lot of other stewardship programs are in the amount of support staff within stewardship that we have.
Certainly true.
So like I mentioned earlier, we have 4 infectious disease / stewardship pharmacists dedicated to our stewardship program, with 3 infectious disease physicians, each with half of your time dedicated to it. So excluding even the fellows who are in on this as well, and the ID pharmacy resident, we have 7 people that are able to split up this call. That was our biggest reason, I feel like, from a stewardship side of success. I feel like it would be much more challenging if you had if you were led by an infectious disease physician and 1 pharmacist that had part-time. It's going to be very challenging to have a workflow where you're getting called every time there's a gram-positive in the blood, and then every time there's an ID, then every time there's susceptibility results, to be able to act on those rapidly. So I felt like our biggest opportunity was our staffing, how we're able to respond to these in real time. Yeah, initially 24/7. Since then, we found that there wasn't as much benefit in the midnight to 7 a.m. portion of it, because again, the teams have no problem escalating therapy, and there isn't as much benefit to de-escalating therapy at 2 a.m. when we're able to at 7 a.m. So we were really staffed for success from that portion. So that wasn't an issue for us, but it may be for others. I felt like our biggest lift was the education upfront. It's a change for a lot of clinicians to be able to discharge a bacteremic patient on day 1 or 2. It's just something that they're not used to, because they tend to watch them in the hospital for 4 or 5 days while you're waiting for full susceptibilities to come back. So I felt like it was a lot of working collaboratively and hand-holding and showing them, okay, not only is it okay to discharge them when they're clinically improved and stable at that time, but we also had the ability to call them soon after discharge and follow up with them early in the outpatient setting to really transition their care fully from the inpatient to the outpatient realm. So I felt like our biggest challenge up front was just the education on really getting patients home quickly, that when you had this data, you need to be able to act on it.
And there's been such a increased need for better use of antibiotics and for decreasing hospital stay and decreasing C. difficile. And you're approaching all of these things with the bundle and the system that you created. So it really argues to have this multidisciplinary team to function like this. And you just, as I keep saying, you just have a perfect model of that. So the one thing that I thought was interesting is the way you developed your communication with people. And I just want you to discuss, Dr. Stefano or Dr. Walsh, how important communicating these results are rapidly, because I know at my medical center, if we put something in the computer, I don't know, it might be 12 to 24 hours before anyone looked at it sometimes. particularly toward the evening and such. So I think that could you discuss just briefly how this rapid communication of information to the pharmacy team to take action is so important?
Yeah, I definitely agree. We get calls on a regular basis saying, when is that test result going to be ready? You know, it's really important we have that blood culture result. And meanwhile, it is already interfaced and results have gone across. Lack of looking at the system. Nobody wants to be paged 24/7 for every patient they have, so they don't want to set that up. So they're relying a lot on the primary person on the floor in the hospital to relay that information in real time. I think that in this system, as Dr. Walsh mentioned, with this process and with so many of the processes we have learned that you have to get everybody on board from the beginning.
I could speak to it from a little bit from the stewardship side. The rapid technologies, you have to have the process in place to realize the benefits of the speed. If you don't have the processes in place, the best technologies in the world, if you don't have an impact, it's not an indictment of the technology, it's an indictment of your process. I feel like the process is the most important aspect to realize the potential benefits of the technologies. So, and it's different for different hospitals and different facilities. This is the model at a teaching hospital that have house staff and physicians in-house 24/7. It's going to be a different model that you're going to need for success at perhaps a community hospital where you don't have hospitalists and it's still primary care physicians seeing the inpatients. You'll just need a different model to realize those benefits. This is the model that we utilize to best take advantage of the staffing and the setup that we have to care for our patients, but would easily be able to be tailored to meet the needs of a different hospital that has different staffing in terms of micro stewardship and who's taking care of the patients primarily in the hospital. So I think you would just need to adjust the workflow to best meet the needs of your patients in your setting to realize the benefits of the speed. Because again, the technologies of the genotypic and phenotypic rapid diagnostics are what they are. You need to figure out the way to optimize those benefits because if you don't, it's not on the technology, it's on the workflow, which I feel like was so critical for our collaboration here, why we saw that benefit.
I know when we first started using the Pheno system, everyone used to comment, I can't believe it came so fast, you know, and then once we started producing so many of them and doing it so fast, they'd call and say, well, I'm waiting for it. You know, I'm going, it's 10 minutes from now, wait just 1 minute, you know, it'll be right there. And so I think it really did exceed expectations on how rapidly they could get trustworthy susceptibility information. It was really quite amazing. The other question I had was, did you find that the generation of all this wonderful data that you've been able to produce helped to clearly explain to maybe some of the laboratory budget leaders that the system was worthwhile? Because one of the questions that I get a lot as being somewhat of a long-term user of the Pheno system is, how can I explain that this is worth the cost? So can you answer to that?
Yeah, I feel like that's a big problem in healthcare in general is we silo the budgets, and you may have a fantastic technology that comes out and you're limited by just the budget of the lab, or you may need to utilize a more expensive antibiotic and it only hits the budget of the pharmacy. I feel like that's where, again, the collaboration is so important because you're going to see the benefits from increased spending on the lab silo on other parts that are very important to the hospital, such as length of stay and decreased antibiotic use that are hitting kind of other budgets. So I think it's really important to get your team and your leadership to not be able to view this in a silo of increased costs in one area, but realizing the cost savings that you're able to generate from this, which is really important to show not leadership, but yourself. Are certain technologies, are you getting the most out of them? You're able to realize those real dollars that give you the ROI when you're putting in a relatively expensive technology. You need to make sure that you're not just improving your process measures of, hey, I'm getting an ID quicker, I'm getting susceptibilities quicker, but you have hard clinical outcomes that you're actually improving that are meaningful for patients as well as the hospital. It is real world. We can't just put in multiple millions of dollars of equipment for better patient outcomes, but but forgo the hospital part. So that's why it's really important for us to show the impact for the hospital as well, because there is real important benefits of decreasing length of stay and antibiotic use and C. diff rate. So that's why it's really important for us up front to make sure our goals align with our quality goals in the hospital and the needs of our quality team.
Oh, I very much agree with you. And as you talk of the siloed budgets, it can be extremely discouraging to laboratories to try to develop, wonderful methods and things that can help you as clinicians and help our stewardship team, and then only be scolded because we're spending too much money. And so I think that's something that we all need to work on, generating beautiful data like you have, or at least some type of data that we can use to show how beneficial that these more expensive systems are. And it's really something that I think laboratorians need to work on. Okay, my next question for you is, do you think you're going to have a similar impact when you apply your study to intensive care unit patients? Because I have to tell you, our experience, of course, we might be a very different healthcare system than you. At Cedars-Sinai, we have very advanced care in our intensive care units. And we thought that we would see a greater benefit in our intensive care unit patients, but we, like you, saw a great benefit in the general medical patient, and they were able to leave the hospital much sooner. And we had major de-escalation, where that wasn't necessarily quite as true with our intensive care unit patients. Do you have any preliminary data, or what do you expect to see?
We do have some preliminary data. We've just started the data collection on the ICU patients, and we've seen very similar to the non-critically ill patient. We've had decreased length of stay, again, by about 2 days. We decreased duration of antimicrobial therapy, very similarly, from more than 14 days to under 10 days. And it's small numbers right now, so we are approaching statistical significance on mortality benefit as well, because while our bigger bang for our buck, like you had noticed as well, is the stable floor patient, we still do have our fair share of multi-drug resistant Acinetobacter, Pseudomonas, ESBLs, and CRE, where they're not we don't have enough resistance that our empiric regimens typically treat those. So we do have a fair amount that are on inadequate initial therapy where this did dramatically help. And those are kind of the attention grabbing stories of the patient that didn't have risk factors, that had the resistant gram-negative in blood. You're able to get on effective therapy at 7 hours as opposed to 2 days when the mortality risk would be through the roof in a patient in shock. We do have those sort of stories, and those are kind of well described with a lot of the phenotypic data from Accelerate. So we do have those, and our preliminary data does show that we've seen that benefit there as well.
So you're going to have a benefit across the board, and that's going to be extremely advantageous for you. That's great news. Dr. Stefano, I have a question for you.
Yeah.
Is there anything that your laboratory has developed in the way of an algorithm to possibly lower your percentage of failure rate, such as putting organisms in the cartridge that ID fails and you're not able to get a susceptibility? Do you have any words from your vast experience?
Yeah, I think that we have two main issues that we've seen in the past year or so. One is the failure of someone to adequately mix the blood culture so that we're not seeing a representative of the, a good majority of what's in there when we're doing, one, the gram stain first, and two, when we put it on the Accelerate. So, just mixing it for the gram stain isn't sufficient. You really need to go back and get a homogeneous mixture for the Accelerate as well. We also, have been fortunate for years to have very seasoned experts in microbiology. And in the last couple of years, we've seen a lot more new, younger generation come on board, and they're just not as adept at or experienced at identifying gram stains quite as well. So we now have two people, one more seasoned, look at all gram stains before it's reported out, because it may be that there is a polyclonal mixture on the gram stain that someone less experienced can't identify. And therefore, we have the ability for a second, more seasoned individual to really kind of look at that gram stain and be sure, so that we're not moving in the direction of the Accelerate only to see a failure. The other main population are the anaerobes, and they just simply aren't going to grow quite as quickly. And that's the main reason that if we end up finding that it's an anaerobic infection, ultimately down the road, it doesn't mean we don't identify anything on Accelerate all the time. Sometimes maybe, sometimes not. but we always have our backup culture plate, and we continue to work that up whenever we see something that's different. So I think we're able to catch that, and that just took time and process workflow.
I would agree. And it's experience with using the system, and everyone kind of needs to develop their own algorithm that works best for their laboratory. But I do agree with you that really a good look at the gram stain with educated eyes can really help choose the proper blood cultures to take to the Accelerate system.
Correct.
This is for both of you. Are there any unexpected findings in your study that you would like to share with us?
The one thing that from the physician side that was interesting is it did dramatically increase the percent of bacteremias with an infectious disease consult. We had always had our stewardship team review blood cultures, but now that we're reviewing them rapidly in real time with this, and we're discussing with the teams, it became apparent how many misconceptions there were about management of gram-negative bacteremia, that a lot of them really led to more infectious disease consults. So that's where I feel like it was really our bundled approach using the Accelerate Pheno, and not just the Accelerate Pheno itself, but really putting that structure around it in a bundled fashion, where we were able to see that benefit. Because just having the Accelerate Pheno wasn't going to necessarily decrease our days of antimicrobial therapy. I felt like it was tying that to the audit with real-time feedback and education to the primary teams that really helped drive a lot of it too. So I feel like the technology is fantastic, but they're only as good as the structure you put around them. And I felt like we were able to educate much more on the management of gram-negative bacteremia by putting that structure around it, which led to not just the better process measures and better time to optimal therapy, but shortening the antibiotic therapy was really a function, I feel like, of the education that came along with the entire process for how do you manage gram-negatives in general.
And Dr. Stefano, did you think there were any unexpected findings in the laboratory side of things?
I did. I think that, again, not having a lot of experience with doing two of these processes at the same time, the initial workload was there. And so in order to really collect all the data points, we really did have a lot more time and effort, if you will, from the laboratory side to be able to show that this was effective. From a director perspective, outside the laboratory, it was really easy to see how this could benefit, but the actual day-to-day operation was probably more intensive than I thought it was going to be initially to do the proving of, our standard of care versus the Accelerate. But I think once we got over that first hump, it was really the second most interesting finding we found, and I think it was great education for the lab staff, was that one automatically assumes that your standard of care is going to be correct, if you will, in a discordant situation. But when we do blood cultures, this is what we always report. So this has to be the right answer. And it wasn't always the right answer. And there were times when we had a discordant result and Accelerate would do the broth microdilution. And some of the time it erred on the side of Accelerate's finding, and some of the time it erred on the side of, our standard of care finding. And I think it was really important and has now led a lot of education for our group that no system, no matter how technologically advanced it is 100% accurate. And so you really have to rely on your gut. You have to rely on what the results are showing you. You can't just say, oh, the system said X, it's X. And so I think that's gone a long way from the lab perspective on educating folks, both our seasoned as well as our new technological staff that have joined recently.
I'm so glad you brought that up, because I think that physicians want things to be 100% and always perfect. And I wish they were too. That would make life a lot easier for us, but they aren't always perfect. And so if you're not around to discuss, do you have lead techs or an algorithm in place for if you get certain susceptibility, certain things are to be repeated or done in a different way?
We have started to develop that algorithm. Clearly in the beginning, there were certain organisms that we needed to verify, and some of it was software based on Accelerate's end, which has now been improved, and some of it was on our end. So we constantly evolve our procedures based on what we're seeing, both population of patients as well as the testing results that we're seeing. And we do have a manager and a supervisor on call, or on staff, I should say, in the building 24/7. So that helps a lot. On the overnight shift, that's the hardest part really for anyone. But now that we don't have to have it 24/7 action from the physician. If there's a concern or a question, they will note that so that we overlap all of our staffing so that they can talk with the supervisor or the manager on one end of their shift so that they can really relay their concern or their lack of confidence. And we make sure that a second person or a second result is obtained before reporting it out.
So my final question to both of you, is there anything that you're going like, why did she not ask me this? I really wanted to talk about this issue. So can you share your ultimate words of wisdom, Dr. Walsh and Dr. Stefano, about what you want people to understand about your study and about the system?
I think we covered everything that was important to me and all of my really lessons that I learned and take homes from working through this for the past couple of years. To me, the most important is having your ducks in a row up front, making sure you have a collaborative approach and buy-in from all of the key stakeholders and bringing everybody on board beforehand to ensure that the technology that you bring in, whichever it is, meets the needs of your patients as well as all of the key stakeholders. So it's not just the lab and your stewardship team, but the people, the folks caring for the patients. So what are the needs of your hospitalists? What are the needs of your intensive care unit doctors, your critical care doctors? What are the goals of your quality team? And what are the metrics that they're really struggling with that you can help by utilizing a comprehensive strategy for a disease state? So it's not just the process change of I'm getting results quicker, but what am I going to do with those results? I need a process in place to rapidly act upon them. And how can that help meet the needs of our quality team, our hospitalists, our critical care medicine physicians as well, because it's a given that you need to have the buy-in and collaboration of the micro lab and stewardship to realize any impact from the technology, but to really optimize the impact of the technology, you really need to be aligned with all those other key stakeholders as well.
Thank you. Dr. Stefano, what are your final words of wisdom?
I think it's important to know the workload and the staffing needs up front. So you really need to have well-defined what the goals of the study are. We need to get buy-in from the laboratory because they are the boots on the ground, if you will. They're the people that are really doing the work, and adding to their workload needs to have a reason, and they need to understand that reason. I think all too often it's easy for the leadership to communicate back and forth about why we need certain testing, why we need certain equipment, and we fail to adequately convey that information down to the staff that are really doing the day-to-day work. So I think it's really important to make sure that all stakeholders, as Dr. Walsh just mentioned, are involved in the decision and in the implementation, and don't be afraid to do the extra work, because at the end of the day, it can really benefit your patient.
Thank you for those words. And I thank you both, Dr. Walsh and Dr. Stefano, for a very interesting discussion. And I thank you for a wonderful presentation. And I think we're finished for the day. And thank you very much.
Our pleasure. Thank you so much for having us.